I request Dr. Prince Ipan, the co-chairpersons, to come up on stage. Dr. Srini Edaklon, convener. Dr. VGK George. So we are going to have a great session, a potpourri of topics, and a few speakers are not available, but then we will have those topics covered by other speakers. And our first speaker is going to be Dr. Arvind Moria. Arvind, he is a young and dynamic surgeon at present at Hyderabad All India Institute, head of the department. And Arvind, start your talk.
Good afternoon all. Thank you Dr. Arup sir, Dr. Srini, Dr. Sujit and Dr. Gopal S. Pillai for giving me this opportunity. Greetings everyone. Thank you Scientific Committee for giving me the opportunity. In this film, we aim to demonstrate an efficient new technique, sieving needle microcapsulotomy, to avoid Argentinian flag sign during capsular access in patients with intermittent pearly white mature cataracts. The authors have no financial interest in the subject matter of this film. Argentinian flag sign is a well-known complication during capsular access in intermittent white cataracts, which typically arises instantly after initial prick with a sharp hypodermic needle on a stressed out tense anterior capsule. Till date, it was believed that the raised intralentricular pressure along with forward thrust of nucleus is solely responsible for propagation of the initial prick into a radial capsular tear. To counter this, several techniques including the small needle aspiration technique had been described to decompress the bag, but peripheral extension of the capsular tear has still been very frequently seen after pricking the capsule with hypodermic needle even before the aspiration of the liquefied cortex is initiated. It means there had to be some other factors responsible which assist the raised interlentricular pressure to propagate the spreading of capsule after the initial prick. On extensive clinical evaluation, we came to know that in reality, it's not the raised interlentricular pressure or forward thrust of the nucleus which causes the extension of the tear. There is one more important factor which is mainly responsible for the extension of the tear is the configuration of the initial prick created from the anterior capsule. Sharp tip hypodermic needle or the rhexis forceps while puncturing the anterior capsule always creates a linear cut configuration with discontinuous open edges along the plane of the needle. Since these forms of cataracts have liquefied hyperhydrated swollen lenticular material with an increased intralentricular pressure, relatively makes the anterior capsule tense and stressed out. Tense and stressed out anterior capsule with an optimum intralentricular pressure triggers of a disruptive forces along the edges of the linear curve and help the cut to open up and propagate towards periphery along its margin and splits into a complete capsular tear. The disruptive vector forces always act along the axis of the linear curve. That is why the tear always extends radially along the open margins of the cut, but never perpendicular to the linear cut. This confirms that it is the linear cut configuration with open edges which has the potential to spontaneously open up and extend to the periphery. Henceforth, we came up with a hypothesis that if we were able to manually create an opening in the anterior capsule which had a round regular configuration like a capsulotomy in true sense instead of a linear cut, we may provide resistance against disruptive forces, thus preventing Argentinian flag sign. Round hole microcapsulotomy with round continuous circular edge without any discontinuity do not tear away with a sudden outburst of the intralentricular fluid with disruptive forces generated by high intralentricular pressure. Simultaneous evacuation of the liquefied cortical material through the hole decompresses the capsular bag and allows for intralentricular pressure to equilibrate prior to the creation of capsular axis. To prick the capsule, we developed and designed a novel instrument, sieving needle microcapsulotomy, with round pointed tip like a sieving needle system. The tip is approximately 0.75 mm in length, 0.60 mm in diameter, and is angled at 90 degrees to the distal shaft. Sieving needle microcapsulotomy, when puncture the anterior capsule, creates a round hole opening with a smooth margins, unlike the linear cut produced by the sharp needle. In most of the cases, single microcapsulotomy is sufficient to decompress the bag. But in some cases, multiple microcapsulotomies are required to evacuate the multiple fluid pockets in the lens. To achieve successful microcapsulotomy after routine incision, the anterior capsule is stained with 0.06% trypan blue dye to enhance the visibility. Ophthalmic viscosurgical devices is injected to maintain the deep anterior chamber with appropriate pressure. Using the main or the side port corneal incision, the sieving needle microcapsulotomy is then inserted into the anterior chamber. Tip of the needle is placed vertically over the center of anterior capsule under direct visualization. Tip is then moved downwards to penetrate through the taut anterior capsule. Round pointed tip of the sieving needle microcapsulotomy creates a round opening with a smooth margins at the center of the anterior capsule. Pressurized intralentricular fluid gushes out as a volcanic eruption through the hole, which decreases the intralentricular pressure and helps in the decompression of the capsular bag. Complete evacuation of the intralentricular fluid, including the posterior compartment fluid, is achieved by tapping and pressing the anterior capsule posteriorly with the help of an air cannula. Once the capsular bag decompression is complete, anterior chamber is reformed with the help of cohesive visco to pressurize and flatten the anterior capsule, and intended 5 to 5.5 mm of capsular axis is initiated after tearing the central hole using a Rexis forceps and easily completed without the risk of peripheral extension of the capsular tear as seen in both these cases. To conclude, sieving needle microcapsulotomy with circular round hole puncture of the anterior capsule along with pressure decompression is the simplest of technique which enables us to successfully prevent Argentinian flag sign with very little effort and much easier surgical maneuvers. Sieving needle capsulotomy is simple yet highly effective novel tool and is an ideal device to open up the tense anterior capsule, adequately decompress the bag prior to the initiation of the capsular axis. Thank you so very much for your patient listening.
It was a nice presentation.
Thank you, sir.
Well explained. I mean, everything is self-explanatory in that video. Very nice.
Thank you, sir. Thank you.
Sir, how many cases you have done this technique?
A randomized trial is going on versus small needle aspiration and this technique. So the sample size is 157. So we have done 88 cases till now.
Okay, and even a single case, there was no Argentine?
Not a single case. And 2 cases in small needle aspiration, they have extended. But it's not significant. We need to wait till the final data is.
Okay.
Yeah.
Okay. No, because the other technique is you can just puncture using a 26 gauge needle and aspirate simultaneously, no? So
Yeah, that is the small needle aspiration I'm
Yeah,
talking
yeah, yeah.
about.
So
but
this is superior in your.
even in that technique, the first initial prick we are making, so the
It can
26
extend.
gauge, it's irregular. You see, if the configuration of that 26.5 gauge needle, it's irregular. That's why all the extension are means radial to the to the initial prick. It's never perpendicular. So it's because of the initial configuration that is irregular.
Yeah.
Right.
Yes, yes.
Yeah.
Okay.
Thank you.
Okay, thank you.
Now I invite Professor Rajesh, RV Center. He was my just senior at that time, for his talk on cataract surgery in eyes with central corneal opacity and haze.
Thanks a lot, Prince. I would once again thank Kerala State Ophthalmic Society and this Drishti and the organizing team for having me here. I'll be talking about managing cataracts in eyes with corneal opacity and haze. When you have a corneal opacity with cataract, the ideal scenario is to do a corneal triple procedure. You remove the opacity, you put an IOL, and the patient will have a very good vision. But there are certain scenarios wherein the patient has a badly vascularized cornea, wherein the risk of rejection is very high, or if the patient has a other eye thicicle, is one-eyed individual, the high-risk grafts, and the opacity is not obscuring the whole of visual axis, it's partly obscuring. So in such cases, doing a cataract surgery and providing an ambulatory vision, something around 636, 624 for the whole life is better and safer than doing a corneal triple procedure wherein the patient is subjected to graft rejection if it's a high-risk graft. So doing cataract surgery is good in such patients. The only thing is that there is a difficulty in visualization, and the reason for this presentation is to discuss about ways how to improve the visualization. So the first and foremost thing is a well-dilated pupil. The first and foremost thing is a well-dilated pupil. That is most important to improve visualization of the lens, and it's better to do it under a block because sometimes you have to do an iris manipulation, etc. You have to cut it, you have to release Sanicke, etc. So all these things may be required. You may have to do some pupillary, changes, some sphincterotomy, etc. So all these things, it's better to do it under a peribulbar block or a subtenon block. Then to improve visualization, trap and blue dye has been used. When the time it was introduced in the year, I think it was in late 90s, 98, 97, wherein trap and blue dye was introduced, and it really changed the scenario in white cataract. And similarly, if you have any opacity in the cornea, any haze in the cornea, if you put trap and blue dye for a longer period, then it stains it better. It not only improves the chance of having a good capsular rhexis, but while chopping the nucleus also, the visibility of the rhexis margin is clear so that you don't chop off the rhexis margin. Then another important scenario is that if you have an opacity something like this, of this size, then if you are doing a capsular rhexis, don't leave the capsular flap behind the opacity. Bring it in the area where you can see. So this is a clear cornea, so leave it here and then again hold it and then complete the capsular rhexis. These are small little things that one should be careful about. A good hydro procedure is essential, and then you can go ahead and complete the procedure. Use of viscoelastic inside the eye in the anterior chamber is again very important, and use of viscoelastic over the cornea is also very important. In cases of haze, if you put a blob of viscoelastic, suddenly the visualization behind improves. It improves significantly. Even during chopping, if you put a blob of viscoelastic, suddenly the visualization improves and you can go ahead and complete the chopping technique. As I said, good quality viscoelastic with chondroitin sulfate should be used in these cases because many of these patients have a compromised endothelium. Now, if you have an opacity, something like this, you can go ahead with and complete the cataract surgery if the cataract is not very hard. But this is a almost black cataract. In such a case, it is advisable that you should have as large pupil as possible. So, even if you have a 5 millimeter size pupil, it's better to put the hooks so as to enlarge the visualization of the nucleus so that you can complete the chopping and go ahead and perform the procedure safely. And sometimes in a central opacity, you can do a slightly eccentric crater and then you can chop. Don't go too much into periphery, but slight eccentricity can help in these cases. Use of endoilluminator is again very useful. When you are chopping the nucleus, then use it from outside. You can ask your assistant to hold it from outside and you can chop it. The visibility is good and you can chop the nucleus and completely emulsify. But once you have emulsified the nucleus and you have to hold the epinucleus, then you take it inside and then it will help you to delineate the capsular margin and the epinuclear margin. So it is very essential to use it from inside so that you can completely remove the epinuclear material and so that you can have a safe surgery and a good outcome of the procedure. So this is how it helps. You can see the epinuclear plate completely coming up and you can aspirate it completely. Chandelier illumination is again a useful tool in haze. If there is a slight haze in the cornea, in order to improve the red glow, you can use a chandelier illumination which is fixed in the pars plana. You can see a nice red glow and you can go ahead and complete the procedure. In a case of a peripheral corneal opacity, you can use a toric implant as well, because if it's a central opacity, it's advisable not to use toric implant. It is advisable to use a spherical implant. But if you have a peripheral opacity like this, a little bit of zonal dehiscence, you can do a toric implant after putting an endocapsular ring, because it's a long-standing scar in the periphery for which the astigmatism is not going to change. So in such cases, toric implants can be put. This is one study which we published long back in the year, I think 2002 or 3, when what we did was, in a case with an opacity like this, obscuring the pupil, after performing the cataract surgery, the pupil was made smaller by use of pilocarpine. And then a couple of nicks were made in the pupillary sphincter. So sphincterotomies were done to enlarge the pupil. So this area has been obscured by the opacity, but this part is against the opposite the clear cornea, and it will act as a pupil. And this we published long back, and we had a very good outcome. Now, if we have an opacity, a scar like this, then it's we can combine it with anterior lamellar graft as well. And if we as we cut the anterior lamella with a microkeratome, you can see the performing cataract surgery becomes very easy. So after cutting it, you can see how clear it has become. So you can go ahead and complete the procedure. And once you have completed the cataract surgery, put the IOL, and then you can put a donor lenticule, create a ledge, put a donor lenticule, and put multiple sutures like that. So the outcome is quite good. Another scenario, other eye thicical, and this eye had a very badly vascularized cornea. Intraoperative OCT showed that the opacity was extending up to 80% of the thickness of the cornea. So we thought that we can do a dissection, lamellar dissection. And after doing lamellar dissection, you can see that once you have dissected almost 75 to 80% of cornea, you put viscoelastic over the remaining layer of cornea so that the visibility further improves. Complete the cataract surgery. Whenever there is a problem related to visibility, you can always put viscoelastic over the cornea to improve visualization, and then complete the procedure. Put the intraocular lens, and then you can put a lamellar graft over it so as to have a good outcome. In such badly vascularized cornea, it's advisable not to do a full thickness graft because of high risk of rejection. So the idea is to remove the bulk of opacity, and so that you can have a reasonably good outcome for the rest of the life. So in conclusion, cataract surgery with some additional procedures, like if the opacity is obscuring part of visual axis and part of it is clear, then you can do a pupillary sphincterotomy. So cataract surgery in cases wherein it is advisable not to do a corneal triple procedure may be useful in providing a reasonably good outcome for the whole life, making the patient ambulatory. The idea is to improve visualization. There are various ways. You can use strap and blue, you can use OVD on the surface, you can use endoilluminator, and thereby improving the surgical outcome of the procedure. So thank you very much for your patient listening, and I'll be happy if there is any suggestion, any comment.
It was a nice presentation, Rajesh.
Thank you.
Next talk, I invite Arup sir, who needs no introduction. His topic is phaco in eyes with crowded anterior chamber.
We have two speakers missing, have not turned up. So I am covering one topic, and if anybody wants to present something good in video, short video, 5-6 minutes, I see Vanashri, if you have your laptop here, or anybody, just to, in case we have some more time left, we can take it up. So I will be covering two topics. So one, of course, what was my allotted topic, and the second one was what Gopal Raju was supposed to do about IFIS. So I'll do those two talks. So it is always so nice to see a hall packed with the audience, but unfortunately, lunch is happening and we don't have a good audience. But please feel free to interact. And any time you want me to stop and explain something or want to add something, chairpersons and anybody in the audience, please feel free. So I'll be talking about IFIS, what Gopal was supposed to talk about. So, when I compare my current recent presentations last 4-5 years to when the IFIS concept was first described way back in 2005 by David Chang and Campbell, I see that there is there's a huge difference in the videos. So those days IFIS was a concept that was coming in, and my videos showed a lot of turbulence in the anterior chamber, iris fluttering, iris prolapsing out, and really graphic videos. So these days I am not able to get those videos because we know how to manage this condition well, how to pick up those potential cases and how to manage them well. And that is the aim. The aim is basically to ensure that you do a very good and safe surgery for these cases. So this was a gentleman in his mid-70s. He was an IFIS candidate. He was an alpha-1 antagonist. And most of my patients, I do the pupillary limbal ratio. And if the ratio is less than 60%, I assume, even if the patient has no other history of drug intake or no other factors that have been associated with IFIS, I would take an IFIS prophylaxis. So let us see how the surgery goes. This was again on the topical anesthesia, temporal clear corneal approach. Please read the text that is next to the video. I may not be able to read out everything. So make the incisions absolutely perfect. The inferior paracentesis is the first one to go, and it is quite a normal size because only irrigation aspiration will happen through the inferior paracentesis. I use a bimanual irrigation aspiration, so I make 2 paracenteses. If you see the superior paracentesis, it was pretty short. It was not full length. It was not 1 millimeter. And then time to inject intraocular Xylocard that was injected inside the patient's eye. Of course, now I use other cocktails which have been found to be very good in IFIS candidates. So when you make the temporal clear corneal incision, please make sure that it is a very well constructed wound. It goes at least 1.5 millimeter into the clear cornea. Because if you have an wound which is borderline, which is not well done, and have a pupil which tends to iris which tends to prolapse, you are inviting disaster. So anterior capsule was stained with trypan blue dye. Pupil has come down already intraoperatively, as you see here. So some amount of viscomydriasis is achieved. So in these cases, if I'm able to get a 4.5 to 5.5 millimeter excision intraoperatively, even if the pupil comes down, unless it is a supra-hard cataract or a very soft cataract, most of the time a surgeon should be able to manage it. So hydrodissection is performed very carefully. Never be very violent and very aggressive in hydrodissection. Bop up OVD from the inside the anterior chamber. At this stage itself, if you see carefully, there is some tenting of the pupillary margin subincisionally. So that shows that, that keeps you alert in preparedness for the, the IFIS developing due course of time. So again, the iris that was tenting up, that is seen here. You must use a good quality dispersive agent for these cases. I always stabilize the incision with the corneal forceps in these cases. Normally, I'll stabilize the eye with my paracentesis and then hold, and then insert the phaco-tip. I won't do that in IFIS cases because invariably there is a pressure gradient that builds up when you insert the phaco handpiece into the eye, and iris will prolapse out. So, with this technique, the one that I demonstrated, so you separate the roof and the tunnel manually, so you are safe. So after a little bit of sculpting, I decided to stop the nucleus. Fortunately for me, the left paracentesis is pretty small, so the iris has a tendency to come up there, but just a little bit of peaking is visible, but you still don't have any issues, any problems. I perform in this particular case phaco in a little anterior plane because this patient now became a little uncooperative. I thought the eye was becoming hard, so I don't want to have any additional problem. Don't want to complicate matters by by introducing a new posterior capsular rupture related issue. So now, if you see carefully here, see this is something very important. You see the bottle. It's not the bottle. It is the drainage bag. It is almost over. If you see here again, it is 20, and then my nurse had not checked the status of the degree of fill of the drainage bag, and at one point it was over. Only 10 cc was left, and the main machine stops functioning. IFIS cases, I would like to finish off all the steps without removing the handpiece from inside the patient's eye, and the dispersive OVD is injected only from the paracentesis. So what you saw here was again something that could have been avoided. I normally, whenever I have a challenging case, a very hard cataract or IFIS candidate or any wherever I expect difficulties, I always fill up a new bottle, or a new cassette, and new BSS bag. So unfortunately, it happened because we want to minimize entry and exit of the instruments into the anterior chamber, and so OVD was injected. The iris was pushed posteriorly, so that gives you more space for you to push in your phaco handpiece. Again, you see I'm stabilizing the incision and going in. So this is a very, very safe way of introducing the phaco handpiece, and it does not, some people have asked me, does it really traumatize the cornea? It doesn't do it. You will see at the end of the surgery on first post-op day, it doesn't, there's no evidence. In fact, it gives you much better control over the whole surgery. Pupil keeps coming down. Now, one word of caution here is if you feel that you are unable to deal with the progressive miosis, please feel free to use a pupillary device. My go-to pupillary device is an iris hook. You can use any pupillary expander. Just you have to ensure that you don't engage the rexis margin as you engage the pupillary device on the pupillary margin. That is a common mistake that happens in the initial stages. So inject OVD behind the iris, so that we have more space between the iris and the anterior capsule, and for you to engage the pupillary margin. Small chunks of nucleus have to be dealt with because they have a tendency to go in the posterior chamber or may hide in the angle. If you have a thick arcus analysis, you will not see it. So now at this stage only, I have enlarged my left paracentesis because I'm going to do a bimanual irrigation aspiration. If you feel that irrigation aspiration, generally, if it is a thick epinucleus, it may be difficult for you to tackle the epinucleus. So iris hook can be engaged even at this stage itself. So it's up to the surgeon. Why I have not used it, because I thought I'll be able to manage the case safely, atraumatically, without using an iris pupillary dilatation device. So let us see now. Now, this patient was scheduled for a hydrophilic acrylic lens. Some of these lenses do extremely well, and so here, I am so concerned about what is happening into the anterior chamber in terms of small pupil, whether iris is prolapsing out or a patient is squeezing, that the lens comes out flipped. I had not noticed it till the last minute, then got flipped. So now it is always a possibility for you to flip it back. But in this case, I decided not to do it. Pupil had calmed down, the posterior capsule is going forward, and patient is uncooperative. And this is okay because this particular lens is a single piece hydrophilic acrylic lens, single plane lens with equal power, equibiconvex, equal power in the anterior as well as the posterior surface. In case you are dealing with a 3-piece lens, or a single-piece lens which a posterior vault, it gets vaulted anteriorly, you will have a tendency for pupillary block in the postoperative period, and then myopic shift because now the lens is moved forward. So no such thing was expected here. Other problem that can happen is if it is an aspheric lens, usually it is one surface is aspheric. And in that case, the asphericity goes for a 6, and then postoperatively patient may have problems with, aspherity related issues, So here, no such thing was expected, and surgery was concluded. If you see here, this is just a stromal hydration. Wound is absolutely sealed. Use a Vexel sponge, all cases, to find out whether there's any spontaneous leakage happening or not. Everything went off fine. This is at the end of the surgery. Incision is absolutely fine. This is on the day one. Day one, the patient had some amount of SKs. Normally, I cringe when I see this much of SKs, but in this particular case, it could not have been avoided. And on postoperative day, postoperative 1 week, patient had a vision of 6.6 with a correction of -0.5 diopter. So I routinely use Phenocane Plus or T Ultra for these cases for IFIS candidates today. These are very cheap, and I don't market these companies. I just use them for my patient's benefit. Now, if I have a IFIS candidate who has a complex cataract, very small pupil, a complex cataract, fellow had issues, in that case, I will not take any chance with not using no devices. I'll straight away use appropriate pupillary device to start at the starting stage itself. So now, I'd like to conclude with this presentation by telling that we should be able to pick up the potential IFIS candidates. Any pupil which doesn't dilate less more than 6 millimeters should be an IFIS candidate, regardless of what systemic medications patient is on. Etiological classification is important because, as I just mentioned, you need to know whether it is an IFIS case or not. Most of the time, you don't have the history, patient doesn't remember. Only when you have encountered the problem on the table, retrospectively some relative comes up with an old prescription showing that patient has been on a lot of medications. So use device when the patient has significant comorbidities and a very, very small pupil, and do the surgery as per the guidelines that have been mentioned in my presentation. So this was regarding the talk on IFIS. Any question on that? Anybody wants to add anything? Yeah. Your mic has to be turned on, his mic. Well, his question is there any role in stopping tamsulosin? There's absolutely no role, there's no point. So once the patient has been on tamsulosin, even if for 2 days, what the literature has showed, the effect still continues. So there's no point in stopping it. In fact, a patient may be symptomatic during surgery and there will be more problems. So I won't stop the alpha-1 antagonist.
Does the pupil size has any relation with the IFS? Like, does the pupil size suppose the tamsulosin and pupil is larger,
no, that's what I had mentioned. When I see the pupil-limbal ratio less than 60%, max dilated pupil-limbal ratio, then I consider this as an IFIS candidate, and I will use a device only if it is too small and less than 3 or less than 4 millimeters, and it is a suprahard cataract, intumescent cataract, and things like that. Fellow eye had a PC rent, and I had bad experience in the fellow eye. Otherwise, this is the strategy that I would use.
Sir, if you don't get a history of tamsulosin, before starting surgery, is there any clinical signs by which you can diagnose IFIS? You have to suspect.
Yeah, the
and-
pupil doesn't dilate. If you see histopathologically, there have been a lot of things that have been described. There's thinning, there is a dilator muscle atrophy and things like that. But dilator muscle atrophy can also be seen in, in non-translucent eyes. So that is on histopathology. But when clinically it is just the pupillary size
No,
that
because some of the pupils will be dilating. Even in eyes, some will be reasonably dilated, but once you start surgery, then it's
you saw the same thing. So
Yeah,
that's what I
correct.
mentioned. See, my dictum for any surgery is if the pupil doesn't dilate more than 6 millimeters. There are studies which have shown 8 millimeter cutoff, 7.4 millimeter, 6.4 millimeter. So for me, if it is not dilating beyond 6 millimeter, now measuring 6 millimeter, 6.5 millimeter maybe intuitively may be difficult. You have to take the picture and then you have to measure it. So what we do is I take the ratio intuitively. This is the limbal ratio, this is the limbal diameter, and this is the dilated pupillary diameter. So I mentally calculate. Initially, I got it verified by measurements. Then I found out that after doing 10, 12 cases, that if I just intuitively know, okay, this is 60% ratio or 50% ratio. So anything more than 60%, I think that I'm pretty safe, but anything less than 60%, I will have to take care of potential eye phase. Okay? So this is another patient where a patient with an angle closure glaucoma, patient one is 60s and a prostaglandin analog. Anterior chamber depth was more than 2 millimeters and pressure was in the, I think mid-teens or late teens. And I started the surgery did not really expect much problem. So as soon as did you see that? There was an anterior capsular touch that happened when I made the inferior paracentesis at this area. So I was careful, so I didn't puncture the capsule. So superiorly, when I made the entry, I had to be doubly careful. There's a lot of difficulty while trying to inject the xylocard intraocularly. Patient, there's a Bell's phenomena, and the eye is becoming hard in this situation. So I knew that I'm going to deal with some difficulties, encounter difficulties. And most of the time, it stays. Difficulties just stay stationary. It doesn't worsen. But in this particular case, I mean, the pupil started coming down. The eye started becoming harder and harder. So though air bubble was retained, but you see it was retained with a lot of difficulty. So then I started the patient on IV mannitol intraoperatively, and then I was going a little slow, hoping that the IV mannitol, it takes some time to take effect, but sometimes if you give it in a bolus, it may work earlier. I mean, of course, it is better to plan it out preoperatively. So here, somehow I formed the anterior chamber with OVD and make a capsular rhexis, going slowly. Rhexis was possible, though eye was extremely hard. My incisions were good, so there was no intraoperative iris prolapse from the paracentesis for the main incision. You have to be very careful, because if rhexis runs away to the periphery at this stage, then you are in for trouble, double trouble. You have intraoperative hard eye, and then you have rhexis gone to the periphery, and surely you're going to have vitreous coming, PCR enlarging, and you have to deal with the vitreous. So rhexis is going on smoothly and very carefully. So I'm just waiting for the eye to soften up. It doesn't happen that way. Let us see the rhexis. Rhexis has been done, and it does not happen. So then I decided that I will do a posterior segment decompression. This is something that is not really recommended by posterior segment surgeons, but here I have a good view, and I have been trained how to make a sclerotomy by my partner who is a posterior segment surgeon. So I take a 23 gauge self-sealing trocar cannula system and go behind, adequately behind the 3.5 millimeter behind the limbus, and then do a minimal vitrectomy. And I also digitally try to find out how much softening I have achieved. I don't want to be too aggressive. You can see the cutter. See, this is very dangerous if you're dealing with a nucleus which precludes view of the cutter. So I know the eye has become soft intraoperatively during the vitrectomy, and then surgery goes on pretty well. See here, I mean, the cortical cleaving hydrodissection is done, and the usual technique of nucleus disassembly, and a 3-piece hydrophilic acrylic lens was implanted in the capsular bag. So this patient had done pretty well, managed pretty well intraoperatively, and postoperatively also did well. So this is the closure of the it was self-sealing, so it didn't have to put any suture here. And this is the same, yeah. So this is, how much time do we have left actually? What is the time now? 41, we have another 10, 15 minutes, okay. So basically I'd just like to sum up, okay. So whenever we encounter intraoperative hard eye, in this particular case, I changed my management strategy. Whenever I deal with an angle closure glaucoma, regardless of what the intraocular pressure is with medications, my cutoff was anything less than 2 millimeter anterior chamber depth IV mannitol. So now I give IV mannitol 200 cc to all my patients 1.5 hours before surgery. They visit the toilet and then they come to the theater. And I try to do them under block so that I can give a digital massage. Usually the IV mannitol and digital massage, most of these eyes, they don't pose any problem. So you must detect conditions that may predispose to intraoperative hard eye. So avoid the situation employing proper preventive measures which I have just mentioned. For hard cataracts, the rexis size should be adequate. When you perform a cortical cleaving hydrodissection, burp out the OVD. Why the rexis size should be adequate? Because if you have a small rexis and hard cataract, then there may be capsular rexis block. All right, so fluid collects behind the nucleus. The nucleus is elevated, so there's a block at the equator as well as the rexis margin area. So you may have a postercapsular pupillary snap, a postercapsular blowout. So that is the reason. Then before you perform hydrodissection, burp out the OVD, particularly if you have used Helon GV or Helon 5 or Viscoat. BSS injection should happen in a very, very controlled manner. And when I do hydrodissection, I don't blink. Because if you miss the pupillary snap and if you continue with a routine phacoemulsification without modifying your strategy, you can rest assured that nucleus is going to drop into the posterior segment. So quickly consider the differential diagnosis of intraoperative hard eye. Now the case that I operated, it occurred to me, is it a suprachiral hemorrhage? Now if it is a suprachiral hemorrhage, the red reflex which was seen in this particular case, it would have become duller and duller. Nothing of that sort happened. I would not have known this if I was dealing with a mature cataract. Second thing is these patients experience pain, whenever there is a suprachoroidal event happening. So if such thing happens, then I'll immediately close the incision, refer the patient to the posterior segment surgeon, and usually they follow up the patient with ultrasonography. 2 to 3 weeks later, they intervene, they remove the suprachoroidal hemorrhage, and then we complete the surgery. So in all other situations, and other situations, you use IV mannitol, and sometimes you have intraoperative hard eye. Everything goes on well, but at the time of IOL implantation, you find that there's no space for you to place the lens. And it will be fraught with hazards like damaging the corneal endothelium, PC rupture. So in many situations, I have postponed such surgeries. If it was the initial time slot, then I have taken up as the last case after giving IV mannitol. Eye is absolutely soft. Some patients I have taken up on the next day. So you must remember that we always remember to counsel the patient that sometimes the IOL implantation may take place at a different stage. Otherwise, the patient will be confused if you schedule him or her for another surgery for IOL implantation. Limited pass band of vitrectomy is always controversial, and it should only be done by a surgeon who has been trained into it. Some people have advocated pars plana aspiration of the vitreous, and it is in fact reported in JCRS a couple of years back, 6-7 cases somewhere in Australia. Patients seem to have done well. But that is again not a very logical thing to do, not a very scientific thing to do. So this is what I wanted to tell about intraoperative hard eye. So Vanashri, you are ready? Anything? Any questions anybody has on this topic? You come up, please. Yes. Yeah. Yep. Okay. So bolus dose of IV mannitol, see, normally this thing should be pre-planned. I should not have done that. I would have given it 1.5 hours before, So here I pushed off maybe 100 cc in about half an hour's time. I have all my patients under anesthetic care, and anesthetist is always there in the standby, and I won't do anything without his, approval. If you don't have a facility for PPV, you have to postpone the surgery. You take out the patient at a later stage, IV mannitol and all that, and then take him up.
Okay.
even then you won't advise withdrawing.
No, it is past PP vitrectomy is definitely better than aspirating with a needle. Yeah. Vanashri, are you ready?
Yes. So thank you so much for giving me the opportunity to speak in your session. I have a small video. I would like to discuss some scenarios of difficult capsular access actually. So is it, can we have the video on the screen please? Okay, so as you can see, this is a fairly intermittent cataract, and what I decided is to make a very small capsular access initially. Let me just play it from the start, 1 second. Yeah. So the plan is to make a very small capsular access in the center. This is a technique of double rhexis, and I choose to complete it with the microrhexis forceps, go in with the cannula, and decompress the tense fibers from multiple directions so that in the mid-periphery you have a less tense capsule. Then I went and tried to enlarge the capsular access, but it became a very small another capsular access, so I went and took a nick with the scissors and then again tried to enlarge the capsular access. Here the important point is that you have to grasp and re-grasp so that your direction is proper and it doesn't extend to the periphery. So at this point, it was difficult to progress ahead, so I changed my direction, went in with my right hand so that I have a better control over the rhexis. Again, grasp it, refill the anterior chamber so that it is flattened. Go in with the microrhexis forceps, grasp near the advancing edge, and then you have a decently sized capsular access. Now here what happened this case, it was an intermittent cataract with a moderately small pupil, a female patient. I had not expected the pupil to come down, but it had started coming down, and as you can see, my rhexis margin has already gone under the pupillary margin. So I went, grasp again, and I'm not happy with how the flap is, the direction of the flap is. So I went in again, put in viscoelastic to try and get, I'm a left-handed surgeon, so my preferred hand is always the left hand. So here I'm trying to take hold of the edge, but I'm not able to take hold. As you can see, I'm struggling there. So I decided to use a Kruglan's hook, go underneath and see whether has it really gone and extended right up to periphery. So luckily it had not. So under visualization, I could take hold of that flap and then complete my second rhexis. Now in this third scenario, what happened was again an intumescent cataract, but as you can see, the capsule is very friable, and when I did the small rhexis, I'm going in to decompress the fibers. I went through the side ports, decompressed on one side. Then I went through the main port. Here, in enthusiastically trying to decompress the fibers, I had touched the capsule and there was a slight extension. You can see inferiorly, and then I thought, let me take a nick over there, 2 nicks, so that I can try and save the situation somehow and doesn't go to the complete periphery. And it was just a very friable capsule where I was not getting a proper rhexis happening. It was breaking up into smaller particles, and I had a fairly decent opening. And now when I started my phacoemulsification, I was always careful that there is going to be an extension probably right under my phaco probe. So I had to be slow. And it was luckily a very soft cataract, so it just kept coming up into the pupillary area. I wanted to finish the phacoemulsification in one go so that the AC does not collapse and the rhexis margin may extend. So that was constantly on the back of my mind, that the capsule is very friable, so not to touch it with my dialer or cause a more iatrogenic trouble. So when you want to come out, it is very important that you refill it with viscoelastic. Now here I had to refill this viscoelastic for continuing my phacoemulsification. So I did not choose to bring my phaco probe out. And in one go, as you can see, I'm nearing the end of my phacoemulsification of the nucleus. So once this was done with, do not come out with your phacoprobe, refill the anterior chamber completely so that the bag doesn't collapse. Now I use the bimanual method, and here avoid the area of extension. Now you can very clearly see that the rhexis has extended to the periphery, and I am choosing to go in that end, in that area very much in the end to just pull out the fibers very carefully. Now the lens that I had chosen for this patient was a single piece IOL, and since it was, the extension was not much to the periphery, I decided to go ahead with the same implant, carefully tucking in the trailing haptic away from the direction of the extension. And that was the end of my case. Can you stop the video, please? So the point of importance that I wanted to stress on is in intumescent cataract, there are two things. One, it could be a very liquefied cortex and a very tense capsule that we know that the moment you nick it, it can go to the periphery. In double rhexis technique, the thing is when you take the initial nick, you take it in a circular way so that you don't have an extension and you can control that little area and complete it. I think the important thing is you should use a heavy viscoelastic like a Viscoat or maybe Helon GV so that the AC is very much pressurized and the capsule is pressurized. And one point is like if there is no fluid egressing, then you know that all the fibers are very, very tense. So in this case, even if you have a small rhexis, just don't go ahead enthusiastically to complete your second rhexis into a big one. Decompress all the fluids. Yeah. So, yeah, so ensure that you have decompressed all the fibers and then only go and make your second rhexis. So any points that you would like to add on this?
Yeah, I think very well presented videos. So I would not, I would advise you not to make such a small primary rhexis, because if you make such a small primary rhexis and you try to remove the cortex from underneath, there's always a possibility of you stretching the rhexis margin and rhexis tear is going to happen. I have had these issues earlier. So primary rhexis should be about 3 millimeters in size, not less than that. And it should not also be more than 4 millimeter because then in that case, you lose all the advantages of the double rhexis concept. But I think you managed both all the cases that I've shown extremely well. So thanks a lot, all the speakers, Vanashri, and Dr. Arvind, Dr. Rajesh, and all the co-panelists for being here. And we will close this session. And now we will move on to the next session, which we are all eagerly waiting for.